Hello and welcome. Again, my name is Jamie Singletary, and I am the Director of Alumni and Family Programming. And so I am excited to welcome you to our CE presentation with Dr. Brad Zehring. Dr. Zehring is one of the psychiatrists here at Within Health. And today he is going to be speaking to you about males with eating disorders, presenting his presentation, Hidden in Plain Sight. So without further ado, I will turn it over to Dr. Zehring. Thank you.
Thank you, Jamie. All right, just get this all set up here. I'm excited to be here and present on this topic with all these other great speakers that are at this summit. Really important work being done and being conveyed. We're going to talk about men with eating disorders, and I titled it Hidden in Plain Sight because what we're going to look at in terms of what are some of the gaps that we have in understanding men with eating disorders. As clinicians and as community members, we understand that this exists, but there are gaps that have happened. And part of it is understanding how we got to where we are with the gaps, how we educate ourselves through the gaps, and how we push through them to advance the field forward. First, before I get started on objectives, I just want to mention I have no financial disclosures. And then I wanted to make note of, if in this talk the terms obese or obesity are listed, it's a direct quotation from the literature itself, still indicating size bias that's in the medical literature. It's something that needs to continue to evolve and work through. And also it's part of the conversation that we're going to have today, is part of why men who, as we're going to see, can typically be in bigger bodies are missed in eating disorders themselves. And we've seen this as an eating disorder community of how if we're looking for eating disorders, we're missing them. And this is just another area that we're going to see that, but I wanted to make sure to make mention of that. So one of the first things that we're going to look at is understanding the historical context at how we've gotten to this point, understanding eating disorders and how where it's come from has impacted boys and men with eating disorders. And part of that is understanding the differences of symptomatology in men versus women, and how a female-centric assessment and screening process has really led to missing atypical symptoms or different symptoms that present in men. Part of this is what we're going to look at and think about is muscular ideal versus thin ideal and the ramifications of that in screening, assessment, and treatment. And then understanding, as we see the research, where do we need to continue to advance the awareness of men with eating disorders to reduce shame of seeking treatment? And even before that, focusing on the prevention and early detection of men with eating disorders. So this is a slide that I put at the beginning of all of my talks, and it just happens that this talk, it's really important and critical and central focus to what we're doing. So whenever I talk about this is what the research says, this is what we glean from the literature, we have to recognize that there's limitations to that. And we know that there's going to be an underrepresentation of male in eating disorder communities. It's a minimized population with how we're looking at how we've been trained to think about eating disorders. They're going to present differently, right? And one of the things that we're really hammer home this point is less than 1% of contemporary peer-reviewed manuscripts in anorexia nervosa specifically relate to male presentations. And we know that anorexia nervosa is the most studied of eating disorders that we have currently, and to have less than 1% focused on male presentations is pretty stark. The LGBTQ community, obviously we know, is a population that we really need to be focusing on in mental health in general. And especially in the eating disorder community as well. Oftentimes it can be more acute mental illness present, worsening eating disorder symptoms, and we don't have as much understanding and research into this, and that needs to continue. BIPOC community as well. Eating disorders do not discriminate. There's this place that we know that this community is not doesn't have access to care as much as other populations may. And this is a continued spot of focus that's missing in the literature and in the research, and then consequently clinically. And then this idea of evidence-based or gold standards, right? And I'm going to mention gold standard, I think, once in this talk, and we'll talk about that then as well. But we have to be really careful about what we say is evidence-based, right? When we talk about evidence-based, we're really focusing on, well, what was done in that research article, what was the protocol that was done, but also who was being studied for that article or that study. And then really being careful how we extrapolate that out to different populations. So I'm going to be throwing a lot of information at you. Sometimes I talk faster and I don't have pictures in this presentation, so I'm going to do my best to entertain you. But also one of the ways that I like to do is kind of give what the talk is going to have and what kind of things we're going to be focusing on. So one of the things I've already alluded to is there's an underestimation of the prevalence of eating disorders, of our understanding in the literature of males, both of all youth, adolescent, and adults. Right. So that's already underestimated in any of the statistics that I'm going to put on here today. There's 50 to 60 years of history that we have of perception and perpetuation of eating disorders as female-centric. So with this, that's definitely hurt research efforts, but also screens and assessments that have been validated have been female-focused. And so we're going to see how that misses males with eating disorders. This thinness-oriented body image characteristic of traditional eating disorder framework needs to be reevaluated and adjusted. We have to have an increased appreciation of eating and body image concern among males. What we do know is body image is a huge proponent in males as well. It's just going to look differently, and we're going to look at that. As part of an evolving field, we have to work on advancement of identification, assessment, classification, and treatment into males with eating disorders. And the reason being, and we're going to look at this as well, is that males are going to present with symptoms as severe as their female counterparts. And oftentimes, due to the lack of awareness, education, prevention, oftentimes they're going to present more acute and sicker. And so that's something that we're going to have to remedy. And the hopes of all of this, as we understand more, as stigma is reduced, as we remove barriers for males seeking treatment, hopefully treatment for males with eating disorders will increase. So to understand how we've gotten here, let's look a little bit historically at the context here. Eating disorders are among the most gendered of psychiatric illnesses, right? So about 100 years of anorexia nervosa is thought to be female-oriented. A lot of it's how it was described in literature. And it wasn't until later on that male eating disorder presentations were start to be noticed in different ways. Now, weight loss was seen with males, dietary restriction, disordered eating were seen as males, but they weren't chalked up to as primary to the eating disorder. They were seen as secondary to a more general psychiatric illness. So if there was weight loss, if there was problems with appetite or eating, it was more focused on depression, anxiety, trauma, things like that, rather than the eating disorder itself. So we already know that the medical field has a long way to continue to grow. There's paternalistic, misogynistic components to the field that we have lived through. And one of the areas of this is when they had started recognizing that males could have anorexia nervosa, they had to change the thought. They were thinking of anorexia hysterica as a term to use for this presentation. But since males could also have this, they felt the commonly held belief was that men are not hysterical, so we can't have it be anorexia hysterical. We need to have it listed as anorexia nervosa. It wasn't really to the 70s or 80s that we began, 1970s, 1980s, that the numbers of males with eating disorders really started to show up within specialist ED clinics. And researchers then started to understand that, hey, there may be something here, we need to look into this. And really the 1990s is when systemic research started. A lot more studies began to be developed. There was a broader understanding, I think, that it existed, at least to a 5 to 10% of cases. And so that's 30 years ago. And I think what's important to think about that is that's not a long time when we're talking about science. We're talking about the human body. We're talking about disorders. We're talking about brain and body health, right? So it's in some instances, we've come a ways in 30 years, and in a lot of other ways, we still have a long way to go. This one isn't surprising to any of you, I'm sure. So amenorrhea was in the criteria for anorexia nervosa up until 2013 when DSM-5 was published and it was removed. But as a consequence to this being in the criteria, most of the 20th century literature doesn't recognize anorexia nervosa among males because they didn't fit the criteria for it. And men don't really have an endocrine equivalent to amenorrhea. We'll talk about this later in the talk. There is loss of sexual interest, reduced levels of testosterone that we can see endocrine-wise in males with considerable malnutrition, but this is definitely not seen in literature itself. And the notion that anorexia nervosa can exist without amenorrhea has really give way to the realization that males can have this disorder. You know, it's interesting though, I talk with colleagues in psychiatry, but also primary care, and this is still not something that's widely known, that this has been removed from the DSM. So I'm going to switch to epidemiology, and why, again, what I'm just going to, when we talk about numbers, these are going to be underestimates, okay? But this is kind of the numbers that are in the literature at this time. So 1 in 4 people are going to be men with eating disorders in the United States, 1 in 5 people in the UK. Australia has similar numbers. Australia also is another place that is doing a lot of research into males with eating disorders. There's some population-based data that suggests that there are no sex differences in the age of presentations of eating disorders. So I think what that also tells us right off the start here is that if we don't know a lot, and we know that there's underestimates within the research, and we know we're not capturing things, how much do we not know? And I think if we can go into this with thoughts of what do we not know, it's going to be a great place to start, because there's going to be data that's going to show it may be way more common than we think and closer in sex differences. And this is something that we need to pay attention to. There's conflicting evidence for age of onset of eating disorder among males, right? That's going to be, you're going to have conflicting data when there's not a lot of data present. And so in clinical settings, we're getting more in clinical settings that see eating disorder patients or eating disorder clinics, if you will. They're going to have higher numbers. They're going to obviously capture more just by the essence of what they do. And so part of the call is for population-based community settings, primary care settings, to really try to capture what's out there, right? Because you're going to probably have the ability to capture people that may not come to a clinical setting, especially men seeking help. And so we can capture who's out there in different settings. Also in non-eating disorder settings, it's not surprising, like in a specialty clinic like GI, that you're going to see patients with eating disorders. And in the study here, they saw an increased rate in males. Nearly 2/3 of those with ARFID were pre-adolescent males. And so we're learning more about ARFID too. But it's interesting that when you start diving into literature, all these different places, males are popping up a lot more. It's important to understand males with eating disorders to help treat their eating disorder. But what's also important is their psychiatric co-occurring disorders, or their psychiatric acuity, is also going to be higher. Cross-sectional data shows us that males are more likely than females with eating disorders to have a greater array of psychiatric comorbidity. A later age of onset, although that's going to be taken into question because we don't know a lot of what are age of onset in males. A history of previously obese or overweight. So in a bigger body, are we already missing because we're trying to see the eating disorder rather than investigating it? And experience weight-related teasing. So back to some of the limitations, but what we really know about the research right now is that the majority of eating disorder studies on males, much like in the female setting, have been done in Western settings on adolescents and young adults and are Caucasian ethnicity. So a limited sample size. And it's important that we think about age because, yes, it's intuitive to think about young adults, adolescents as people to research and think about. But as we know, in female gendered patients that are middle age, older age, eating disorders exist in that population as well. And it bears it out in this last bullet point here, where there's 16 case reports of eating disorders with males aged 40 to 81. And what they found was that the prevalence of disordered eating was almost up to 2% in this age group, which tells us a couple things, right? One, that's already an underestimation, but two, that there's probably sub-threshold. We're not capturing all the symptoms that are happening, but if there's already this disordered eating that's happening, that's some numbers that are popping up, it's probably just the start of the smoke. And more investigation, there's going to be more things that are found in all ages. Other problems that cause lack of full-scale clinical male trials is going to be the atypicality of symptoms. So when I talk about sub-threshold or atypicality, what I'm talking about is what we're going to expand on here in a little bit. This thinness ideal, what is binging, what are body concerns, what are weight concerns, like how these are going to look different. Okay. And if we're set up in a way to be female centric in our studies, we're going to think one way, we're going to miss a whole population. And then exclusionary criteria. So in eating disorder studies, they want as close to a pure eating disorder case as possible to understand eating disorder, eliminate variables. And so sometimes exclusionary criteria can be acute psychiatric symptoms. And we know that men with eating disorders are going to have more acute psychiatric symptoms in general. So if their depression scores are too high, if their anxiety scores are too high, if their suicidality is there, trauma scores are too high, they may be excluded from the study altogether. And so I told you I was going to talk about, or a gold standard was going to come out here, or evidence-based, right? So when we talk about, we have these gold standard assessments for eating disorders, we have to be really careful how we translate that to male presentations, because the gold standard assessments for eating disorders that we have demonstrate a lack of sensitivity in detecting and qualifying eating disorder symptoms in males. So obviously that's going to be an issue. So why is the historical context important? Why is understanding the epidemiology important? It's because if there's unique symptoms and issues that are experienced by men with eating disorders, it may translate into unique treatment needs as well. And so we have to understand the problem to help start understanding the solution. What is known when you look through all literature is similar to what you're going to see in general mental health, eating disorders among any gender, any sex, is that the therapeutic response needs to be empathetic, non-judgmental, right? That therapeutic rapport is going to win out in most every case. And so for men, it's about how are we going to continue to uncover information? How are we going to continue to uncover or provide a space where we can help them understand what they're feeling, what they're seeing, and help connect dots for them. Some therapeutic points of emphasis to start thinking about for differences, if you will. Men are going to need more content on emotional expression and identification. This makes sense to us. They're going to have trouble identifying possibly what is at the core or what at the root, and not even know what's happening or how to identify it. So helping them speak a new language. How do we help them acknowledge the eating disorder itself, right? They're already coming into this as an anti-masculine thing. They're already seeing these barriers to treatment. How do we help them through that so that then they can accept treatment for their eating disorder? And, I think what we're trying to do is we're trying to create these gender neutral spaces for these specific reasons, right? Men can feel ostracized in treatment spaces where there may is not gender neutral, is more to female oriented gender type space or environment, or the reading materials or the packaging or kind of how they talk about it isn't inclusive to males with eating disorders. And so it's important to have a diverse population environment as possible to help decrease some of those barriers. I found this to be really interesting, and this was echoed through a few articles that I was looking at. Safe and sensitive treatment environment does not mean male-only clinicians or male-only groups. And what they found also was that gender-segregated treatment spaces may in fact be harmful to the therapeutic process. And their hypothesis to this was we're creating vacuums, right? And in a space where men are already having trouble with emotional expression and identification, throwing them in with more men can be off-putting or be uncomfortable. So this idea of having a different gender leader or even having mixed gender spaces can be really helpful to encourage and expressing emotion. And this idea of male-only spaces further can help reinforce this idea that they're different, that they're separate. And so by mixing spaces, it's important to challenge the masculine norms or anything that we're doing to inadvertently reinforce male perceptions of eating disorders themselves. We know the gold standard assessment's evidence-based. You've heard me harp on that, but that's important for us to understand when we're thinking about our questioning on exams, our assessments that we're reviewing, to dive in deeper too. This study showed one study of adolescent high school students, only 5% of boys reported an overvaluation of body weight or shape compared to 24% of girls. Later on, we're going to see that body image, body concerns are as prevalent in males as females. We're just missing the way we're asking the questions, right? Because women have an overvaluation of weight and shape predicated on the internalization of the thin ideal, right? Emaciation, smaller. Men have an overvaluation of weight and shape. If they do have it, it does exist, it is impactful, but it's predicated on an internalization of muscularity. So they're not going to perceive this idea of overvaluation of body weight and shape, of losing weight. Am I too thin? Do other people think I'm too thin? Kind of all these things. They're going to see it as, am I muscular enough? Am I lean enough? And another really important telltale difference is men are typically going to present with physical distress, physical injuries, more than emotional distress. And this is important. We're going to see why that is probably so moving forward here. I put this: hearing is greater than seeing. And this goes, we cannot see eating disorder with our eyes, or we shouldn't fall on that we have to be able to look at and then know the whole story. We have to be able to listen. We have to be able to uncover and question, because there's no clinical guidelines for physical assessment of men with eating disorders. They just don't exist. We can't use body weight as an indicator, nor should we in female genders, but body weight we can't use as an indicator of severity, because the medical risk is less reliable in male patients. They're going to most classically be in bigger bodies already. And even the fact that they're in higher body weight, they're still at a greater risk for osteoporosis and bone disease if malnutrition exists at a high level, just like females. So we can't let what we see fool what we need to hear. And there's going to be typically a greater focus on exercise as a compensatory behavior than vomiting or laxatives as a form of purging. We'll talk about exceptions to this. So when we move into the next section here, we're going to talk about eating disorders as a cluster and break it down, kind of the differences of how these are going to present. So one of the things that we know and get repeated quite often through literature is that men are at higher risk of dying of anorexia nervosa than females as a general rule. And possibly the hypothesis to this is that it's diagnosed later in the course of illness in the more acute state. And then we know that there's underestimates of percentages, but we really see here the need for increased population-based studies, community-based studies. So community-based examples of males with anorexia nervosa, almost non-existent. But clinical settings, 5 to 11%, right? So there's a huge discrepancy between those two. Both are underestimated, but we're working toward the prevention and education and awareness to have that number become more similar. This study here, 2 bullet points to kind of break it down, was a study of high school students with anorexia nervosa. And the point that it's going to pose here is where we have to be careful how we determine what symptoms that they have and how it's described. So in a population of high school students, adolescent males reported episodes of extreme dietary restriction at least 3 times per week at a rate of 2%, considerably lower than that of females at 11.5%. In the same study, compulsive exercise was seen to be similar with no sex differences between the two. So men, they're going to talk about compulsive exercise. They're going to talk, that's going to make sense to them. You can ask questions that way, that they're going to mark that as being a behavior that they notice. Restriction is going to look different, and we're going to look at how that's different. And the last bullet point is one of the exceptions here. So compulsive exercise is more common purging behavior in males than vomiting or laxatives, diet pills, etc. The exception is gay males. And we'll look at this in a future slide when we look at sexual orientation. When we think about the difference that we see in literature and understanding about males and females with restriction, the intent really matters here. With females, dietary restriction, the goal is for emaciation. Males, dietary restriction is oriented toward leanness, or the interest of enhancing muscle definition. So men, they're not going to care about the flat stomach. They want the six pack, right? They are less concerned about weight than females, but equally concerned about weight. They want the bigger shoulders, bigger arms, smaller waist, larger thighs, right? The muscularity, the definition. This bears itself out too with higher levels of care, where men are going to present with higher admission BMIs than females, due to probably the different in shape ideals. But as we know, as acute, as destructive internally. So compulsive exercise in anorexia nervosa, how does that look? Similar probably presentation with male and female adolescents in terms of frequency. But by the times of adulthood, males are probably we're going to see that behavior predominate over females later in life. And typically in males, it's going to be the last symptom to remit within the eating disorder and the first to relapse in cases. It's interesting, right? Males are more likely to present physical distress than emotional distress. And one of the reasons that exercise is probably so important, one is this muscular ideal that we'll continue to define and look at, but this idea of affective regulation and the ability for men to cope with emotions and differences in their mood and affect and emotions through physical exercise and endurance, rather than working through emotional and coping strategies that way. They're also going to have more rigid and rule-driven exercise habits, and so much more emotional swings about if they can't follow through on certain habits and rules. In bulimia nervosa, right, again, we're going to see differences between female and males percentage-wise. And with gay and bisexual boys, they reported significantly more likely to fasted, vomited, or taken laxatives or diet pills to control their weight in the last 30 days. Gay males 7 times more likely to report binging and 12 times more likely to report purging than heterosexual males. So we need to recognize that difference there as well. We know even less about bulimia nervosa in males of all age groups. And so this is an evolving presentation for us as well, but there are some nuanced differences, and we'll look at that here now. So men report fewer eating concerns and might not experience as much loss of control as females of the same group. So when we're thinking about binging and the shame and the loss of control that has to go with an objective binge or meeting criteria for a binge, boys are already not going to have that same connection between, they may have the binge and they may binge, but they're not equating the same amount of distress to it. And so it gets missed on standard assessment measures. And body image concerns, right? We know that men have them, but it's more related to muscularity. And so with muscularity, we're going to talk about muscularity-oriented disordered eating, and we're going to expand on that so you understand that, but also this idea of cheat meal or cheat days, right? Which also makes this idea of binging kind of really convoluted at times, where men have muscularity-oriented body image goals, right? Which can bear clinical resemblance to that of binging in bulimia nervosa. This has been long standard in male bodybuilders to eat a lot more food for the purpose of developing more muscle. But we're now seeing this more in non-bodybuilding males in community settings. And a cheat meal can be, there's a lot of restriction, a lot of prohibited foods that you're not allowed to have, but then a cheat meal, everything goes by the wayside. You can have whatever you want, can eat whatever you want to across all foods. And this can be 1,000 to 9,000 calories at a time. More commonly these days is the cheat day. So Monday through Saturday, very strict, very rigid on what they're eating, the frequency of it, the amounts of it. And then Sunday typically is the cheat day, where there are no rules, there is no guilt, just eat whatever you want. And there is a metabolic theory to this. It's this sporadic influx of calories is thought to offset the metabolic effects of prolonged dietary restraint, maintaining a state of ketosis and enhancing the speed of body fat depletion. The other thing about psychological thing here is we know that a lot of restriction at something, or a lot of prohibitive things, are going to make us want it more. And so I think another psychological theory can be of these cheat meals, cheat days, is they restrict for so long, or don't allow themselves to have things for so long. This cheat meal, cheat day allows them also to binge on something that they otherwise aren't allowed to have. The evidence is definitely evolving on what is the psychosocial or affective regulation or dysregulation of these cheat meals and cheat days. I don't think we have a full understanding. I mean, we have a anecdotal understanding of how this can be impactful, but we don't have a full understanding of how it affects men, as we have a better understanding of the psychosocial and affective dysregulation in females that binge eat. Women are going to typically have a preference for sweets and more likely to binge on desserts, where men are going to have the preference to binge more likely on high protein, high fat foods such as meats. Again, societally, we can see where this is going to be harder to see and maybe hidden easier or labeled as problematic. The other thing about binging is we have to understand is that, like I talked about, men, they may report eating objectively large amounts of food that are objective binges, but they're not necessarily going to report experiencing loss of control or distress during these times. And the other thing, so that's hard part about diagnosing the binge. And then the other hard part about diagnosing the purge, if you will, is it's the extreme dietary restriction and excessive exercise that is typically going to be present, rather than purging behaviors that are classic, like self-induced vomiting, laxatives, diet pills that are more quantifiable. So when we're already looking at compensatory behaviors in one way defined, and yet it's a different way, we can see where it's missed. So with binge eating disorder, right, we know that binge eating is the most common eating disorder behavior in males. It's the most common eating disorder in males as a whole. And it's probably in bigger numbers than we know now, because DSM-4, there had to be 2 binges a week to meet the mild criteria, the qualifier. And then DSM-5, it was switched to 1 binge a week. And so mild, moderate, severe is classified based on number of binges per week. Approximately 40% of those with binge eating disorder are male, so a big number. And then here we start to see the differences in the literature again, right? Among high school students, 6% of male students and almost 17% of female students engaged in at least weekly objective binge eating over the past month. And this is the limitation we see in loss of control. So despite the statistics that we see, like 40% of binge eating disorder in males, there are still studies that identify binge eating disorder as being more common in women. Women feel that shame and embarrassment with binging and overeating, where it's going to feel more macho to men if they're in company with overeating, right? And this is the distress, just like we saw with bulimia binges, the same components here. And so remember that the emotional expression and identification is really important with these binges. We may not be able to, the patient themselves may not be able to quantify them as distressful, but they may not be able to express their emotion or identify their emotions in it either. And so the work really needs to be done is, if we're seeing these objective binges and they can describe them, but they don't think there's anything wrong with them or it's impactful, how do we help dive into and connect the emotions surrounding them? Beyond the eating disorder, it's important to identify binge eating disorder, obviously, but men are more likely to meet a comorbid axis 1 disorder. And axis 1 is old nomenclature for a psychiatric co-occurring illness. And this is important because we need to be able to treat that psychiatric co-occurring illness, because it could be contributing to the binge eating itself as well. As I talked about a little bit earlier with bulimia, there's a complete absence of research in addressing the clinical significance of weight shape overvaluation among males with binge eating disorder as variants of the disorder, as we have a better understanding with women and how that shame and judgment drives, and stigma drives the eating disorder itself. So again, a lack of what we have and what we need. So with ARFID, obviously the newest eating disorder that we have, don't know a whole lot about it yet. In this specialty clinic, this study, they saw a group of adolescents, about 14% had ARFID. In their presentation, they were younger and male. Due to not really knowing a lot about it, we actually know more based on community-based samples that show a more equivalent sex ratio of ARFID than we do in clinical settings. But we just don't know really with certainty what we can say about both. Some of the literature we have, not surprisingly, this last bullet point, even though the literature is sparse with understanding, there is a recent study that reported 9.2% of adult patients presenting for ED treatment met criteria for ARFID, and of those adult patients, they were women. So given that ARFID's new, more research needs to be done to understand population prevalence, correlates of the disorder, including the sex distribution. This next group I'm going to talk about, I want to put in there for completeness sake. I mean, each one of these topics could have its own talk, but it's important that we touch on the components of these as well for completeness sake. With athletes, we know male athletes are at risk for eating disorders, especially among sports, competing in sports, similarly to the way women do, with focus on diet, appearance, size, and weight. And to me, this is a big number. About 33% of male athletes are affected. Male athletes, just like male non-athletes, the estimates are underappreciated. So this is already at a third of male athletes being affected in weight class sports, lean sports, and aesthetic sports with eating disorders. That's a big number. And then all athletes face a unique set of eating disorder risk factors related to sport participation. This is performance pressure, team weigh-ins, uniforms, injury, right? This petri dish that are going to all affect the ability for somebody for an eating disorder to exist. Not surprisingly, some research suggests that eating disorder risk is higher among female athletes than male athletes. The problem is all the eating disorder screens that are developed and validated for female athletes, or all the eating disorder screens that exist have been developed and validated for female athletes. And so we can see where we're not going to capture differences or atypical symptoms. And I say atypical is just different than these assessments are looking for. So there was a group that's put together this eating disorder screen for athletes to help fill that gap. And essentially this screen can be given and it focuses with weight. So it refers to numbers on the scale. And so it's going to define it. Shape refers to the amount and distribution of body fat and muscle. Body composition refers to the ratio of body fat to muscle, and leanness refers to low body fat to muscle ratio. So really kind of pinning down symptom or criteria that we would see in males, right? So not just thinness, but really understanding the composition, the intent of the whole encompassing distribution of symptoms that could be present to capture as a screening tool, right? Obviously, the investigative work needs to be deeper. So we talked a little bit about muscular ideal. We're going to talk about it a little bit more. We talk about muscularity-oriented body image concerns and this idea of muscularity-oriented disordered eating, right? And to understand this, we want to be careful of this term called concept creep, which is a psychological term of over-pathologizing a quote-unquote normal human behavior. So the eating spectrum can be relatively wide, and is what we don't know, and because we don't have a lot of understanding of it. I mean, we intuitively can understand things, but to have it bear out, is it causing clinically significant distress? Is it causing functional impairment? Is it part of muscle dysmorphia? And so we're going to look at muscle dysmorphia as well. But this idea of muscularity-oriented disordered eating, how impactful, how destructive is it? Evidence is evolving on this, but up to 60% of all boys in the United States report purposefully manipulating their diet and striving for greater muscularity. So this already puts alarm bells in our ears for what we know about links between muscular orientation and eating disorder pathology. Dr. Stuart Murray, who's an academic researcher at the University of Southern California, and he's kind of the guy that I watch his work and pay attention to his work. Anytime he's the first author on anything, I'm paying a lot of attention to. A lot of the information I'm getting is from him or people that have contributed that he's researched. But him and his group developed the MOET, and really looking at is muscular-oriented disordered eating a problem? And so this is another way to capture for us, not to over pathologize, but to really understand what is harmful. So body image issues, muscularity oriented eating for what, why? And it's this idea of muscular ideal. And so we have to think about movie stars. The Rock comes to mind, male models, how they have progressed through the years, more muscular, more lean, the six pack. Action figures, right? Video games, how these figures are boasting pretty much dimensions of muscularity that are anatomically impossible for humans, but they're continually being shown to us and consumed by us, resulting in 90% of college-age American men reporting a desire for greater muscularity. Boys as young as 6 years old demonstrating a preference for muscular body types. And I was in a meeting a couple of days ago with the psychiatrist, and one of my colleagues, Dr. Caitlin Elsenbeck, brought up, she has young boys, and she was shopping for Halloween, and she showed kind of the male costumes that are out on Amazon, and they're the huge muscles and kind of all of these things. And so it's pervasive throughout all the things that we consume. So it's about trying to understand, well, what is the problem here? Is there a problem here? What is the connections here? Nearly 22% of young men report engaging in muscle enhancing behaviors. We already saw how many think about having more muscle. We already saw how many people are changing their diets to enhance muscle. Up to 7% in the study are using supplements. And so the concern here is not regulated. Are they thinking more is better? What's harmful there? And then we already know the issues with anabolic steroid use and the problems with that. So we can see how this overvalued ideal muscular body type can lead to eating disorder behaviors. And then we can also see how this thinness-oriented framework of eating disorder pathology, how we can totally miss what's happening right in front of our eyes. To further define muscular ideal, right, it's this drive for muscularity and leanness. So being cut, lean, having low body fat, motivated to pursue this with rigid exercise routines, rigid meals and snacks and macronutrients, and really paying attention to everything and when that's not enough, it's going to the supplements, it's going to the steroids to get bigger because it's not enough. It's important to point out that males also endorse a drive for thinness, just as females might report as a desire for muscularity. But muscularity-oriented disordered eating is considerably more common behavior in men. This idea of bulking and cutting. So bulking is increasing that muscularity. Cutting is to get that leanness, right? So bulking is how many calories can I consume? A lot of protein in the effort to get bigger and bigger and bigger. The problem is psychologically, that also causes problems with the leanness part. If I'm eating all of this and I'm trying to consume all this, how am I also going to become lean? So there's a psychological internal conflict, which then increases this rigidity of what I can eat, the cheat meals, the cheat days, but also this compulsive exercise, right? I just need to exercise more. And so this is this constant spinny wheel that can happen. And one of the areas that we know and are developing even more that it's problematic is this idea of muscle dysmorphia. And it was originally described as reverse anorexia. And it was originally studied in male bodybuilders, but had been seen more in males that aren't bodybuilders. But it's this pathological pursuit of muscularity. And it's this core belief in fear. Similar to anorexia, this core belief of being fat, but in muscle dysmorphia, this core belief and fear of having insufficient muscularity and this concomitant drive for muscularity, both of definition and leanness, that creates the pathology. In the DSM-5, it's classified under unique body dysmorphic disorder associated with muscularity concerns. There's a lot of debate here that it doesn't have a home, and that's what the proponents for that it is an eating disorder are fighting for. Should it fall under body dysmorphic disorder? Should it fall under OCD? Should it fall under eating disorder itself? And the fact that it doesn't have a home has really stunted its research efforts and really to understand it more so. But of these next two bullet points here, we see that this is something that we really need to think about. Small-scale twin studies suggest the familial aggregation of muscle dysmorphia and anorexia nervosa in male twins, which bears notable resemblance to the familial aggregation of anorexia nervosa between first-degree relatives. Also, recent epidemiological data suggests that muscle dysmorphia may be as prevalent in men as eating disorders are in women, suggesting that pathological pursuit of muscularity may be the male analog of the pathological pursuit of thinness observed in female ED patients. So again, it looks different. The severity is probably there. The numbers are probably there. We have to really pay more attention to this. Just wanted to drive home the point about steroids, that it's definitely going to be seen in this population. This core belief that they're not big enough, that they're not lean enough. Steroids helps growth and also helps leanness. And we also need to remember that steroid use is considerably more common among homosexual male adolescents than those who identify as heterosexual. So this is my obligatory social media slide that I think needs to be present in every mental health conversation. Eating disorders not to be excluded from that. Just like eating disorders in females, we know that family, friends, there can be environmental causes, right? We know that social media that's focusing on image-based Facebook, Instagram, TikTok, they have algorithms designed to push out this data to reach these people. And the more that they consume, the more it's going to be among that same type of focus. And so there's definitely studies that are showing that greater muscularity-oriented body image concerns and eating pathology are associated with greater body-centric focus of social media. Again, there could be a whole talk on sexual orientation and risks associated with that in eating disorders in men. I did my best here to put a lot of the high points here. Over several decades, evidence has accumulated in support of an association between sexual orientation and ED symptoms in adults, in men and adolescent males. As we saw earlier, gay males report higher prevalence of purging, diet pills, fasting to lose weight. Homosexual and bisexual boys reported significantly greater body dissatisfaction than their same-sex heterosexual peers. At age 16 years, homosexual and bisexual boys had 12.5 times the likelihood of engaging in binge eating as heterosexual boys. And then a study out of Norway, it was a nationally representative cohort, found that male adolescents with same-sex sexual experiences were more likely to report bulimic symptoms than those without those experiences. So definitely a population base that we have to pay attention to, and that can be very sick. I'm going to wrap up with not an exhaustive list of medical complications, because again, not surprisingly, we don't have good lists of what we need to be looking for from medical complication in men. So I'll wrap up with some of these, and then I'll have a future slide, and then we'll open up to questions and discussion. So we talked about we can't use weight, BMI, and I think we're getting better at this as a field of getting away from that anyway, as thinking about severity. But when we talk to people that aren't as well versed in this field, primary care physicians, pediatricians, we need to continue to echo, we can't use body weight as a reliable factor for indicator of medical complications. This exists in males as well. Males typically are going to be insurance companies as well, because I'm thinking about males admitting to residential levels of care with a BMI of 25, but they're sick. And yet insurance companies are saying they have a BMI of 25. And further, approximately 40% of males with eating disorders report a history of being overweight or obese. So we're going to have bigger body sizes already here. Cardiac wise, this was echoed through a lot of studies, but this study I found most interesting. It showed bradycardia, or low heart rate, in males with eating disorders when they presented to a cardiac clinic, and also orthostatic heart rate increases. So all indicative of malnutrition. What was worrying about this was that the male, more than half of the eating disorder patients that were male in this study that presented to the outpatient clinic met criteria for urgent inpatient admission. So a couple of the thoughts were, was this because of the delay and their sickness progressing, or do men possibly have a rapid escalation to instability cardiac wise? I don't think we know the answer to that. It could be all of it. GI wise, men are going to have GI symptoms similar that we see with malnutrition, restriction, laxative abuse, etc., as females. What they saw in hospital admissions of males with eating disorders, that liver enzymes were going to be significantly higher than those in females. Endocrine wise, they're going to have thyroid issues similarly. And it could be this thyroid dysfunction that's responsible for the slowed metabolism, for the low heart rate, for the low blood pressure. That could be part of that. They're going to have lower testosterone levels, lower hormone levels, lower testicular volume. So this could be some more endocrine things that we can look at objectively. And this always catches me. Adolescent males with anorexia nervosa have also been found to have significantly decreased bone mineral density at the spine, hip, femoral neck, and whole body compared to healthy male controls. So they have an elevated fracture risk, right? Greater risk of osteoporosis and bone disease relative to female eating disorder patients. And that's a big one, because the Society of Adolescent Health and Medicine, right, kind of determines who should get DEXA scans. And we have a lot of focus on DEXA scans in females that have secondary amenorrhea or have lost their period for a substantial amount of time. The Society of Adolescent Health and Medicine, though, their standard medical guidelines stipulate that costly DEXA scans should only be administered in cases of eating disorder when amenorrhea is present for 6 months or more. So here again, we have amenorrhea as a criteria to get imaging bone density scan done in a greater risk of bone fracture and osteoporosis in a population that we're not even going to capture, because people aren't even thinking about it, that it's going to happen in that population. So obviously in the absence of specific guidelines for these types of things, males are likely to be marginalized from the best practice of eating disorder related medical complications. So body composition, I've already talked about this a little bit. Males with anorexia are going to have lower percentage extremity fat than some their peers without anorexia nervosa. Probably no change in trunk distribution. And adolescent boys with anorexia nervosa are found to have less severe fat mass deficits than adolescent girls with anorexia nervosa. Again, the higher BMI ideal body weight range that are presenting, but the symptoms can be as severe. So last slide here, future directions. We looked at the historical context. We look at the epidemiology. We know kind of what's out there. We have a better understanding of how symptoms in men can present different than symptoms in females, right? And how we can miss them. So we need more tailored screening and assessment efforts to capture all of that understanding. And we need the research to be pushed in that direction. We need, from that screening and assessment, is going to come more precision treatment for boys and men that's going to directly address the muscularity oriented body image concerns. So hopefully potentially minimizing exercise behavior that's going to be exacerbating their symptoms in the first place, right? So that unique treatment needs, understanding the differences could change our treatment needs that we're doing. We need consistent evidence, given the consistent evidence indicating increased risk and severity of eating disorders pathology among sexual minority boys, treatment that specifically addresses a broad spectrum of gender and sexual presentations, including among those who identify as transgender or gender fluid, is necessary. We just don't know enough. There's a lot that's happening. There's a lot of great people out there pushing this message and talking about this. It needs to be more. And then some of the things that we have in treatment centers, right? Brick and mortar, the logistical problems of higher level of care to have both boys and adolescent girls in the same space. It's difficult, and I understand them, but this further marginalizes and internalizes stigma among young men and families who seek treatment. And so hopefully this is one way that virtual treatment can continue to push this and create these inclusive environments that everybody can get treatment. And then lastly is humility, right? We're all great at what we do. We all strive to do great work for the people that we try to help. We also need to know what we don't know. And it's important to show up that way. It's important to gather that information and to continue to seek the answers that we need to seek and to push this field forward. So thank you for listening. And Jamie, whenever you're ready, we can do questions and discussion.
Thank you so much, Dr. Z. That was an amazing presentation. And we do have a question. This question comes from one of our attendees. They would like to know, where does night eating syndrome fall in all this regarding men?
Yeah, I didn't look into that specifically. So night eating syndrome is going to be where the eating is going to consist of eating overnight typically, right? Not any binging during the day or even evening, but middle of the night. There could be sleep pathology part of that, right? So sleep study is going to need to be important to rule out any parasomnia that could be causing that eating issue. But if we think about it, if it's not a sleep related issue, if it's not due to a medical cause, it's probably the similar types of thing where there's a lot of restriction during the day and then the binging is happening later in the evening or nighttime. They're waking up mentally hungry, physically hungry, and so then they're binging at that time. So I didn't specifically look into that, but my guess is it's going to be similar to what we see with binge eating disorder or binge eating in males.
I'm looking in the chat, Dr. Zehring, and I don't see any other questions. So I will take a couple minutes just to go over some housekeeping. I wanted to share that we appreciate you all joining our presentation, not just this one, but just your participation in the summit over the next couple of days. Also, I want to encourage you to check your dashboard. That is where you are going to find the survey for Dr. Zehring's presentation, along with the link for you to download your certificate. And it would be just unsettling of me not to share that we are hiring at Within. And so this is an opportunity for us to work with very many just accomplished clinicians in the field. So if you are interested in being part of our team and think that you can bring your talents to Within, we are very, very interested. So please don't hesitate to go on our website at withinhealth.com. I will scan the chat just one more time. It does not look like we have any other questions. Dr. Z, is there anything else that you would like to add before we conclude?
Just thank you all for coming and listening, and thank you for all the work that you all do.
Thank you so much, everyone. Have a wonderful day. Bye-bye.